The following presentation is for informational and educational purposes only. It is not a substitute for professional medical advice, diagnosis, or treatment. The experiences and procedures described may not reflect every facility or individual situation. If you or someone you know is in crisis, please contact the National Suicide Prevention Lifeline or call 911 immediately. Imagine the worst day of your life. A day where the floor has fallen out from under you, where your mind feels like a betrayer, a relentless storm you can't escape. Now imagine that day doesn't end. It stretches into a week, a month, and you feel like you're drowning in plain sight. Someone finally throws you a life raft, a place that promises safety and a way back to shore. But that life raft is a hospital with locked doors, a place you cannot leave, surrounded by strangers who will now manage every minute of your day. This is the reality for hundreds of thousands of Americans every year who are admitted, either voluntarily or involuntarily, to an inpatient psychiatric unit. For most people, the inside of a psych ward is a complete black box, a place defined by terrifying movie scenes of chaos and despair. And that fear, that unknown, is one of the biggest barriers to people getting the help they desperately need. This video series is designed to shatter that black box. We are going to walk you through those locked doors, not for shock value but for understanding. We will demystify the entire experience, from the moment you arrive to the day you leave. We'll explore the daily routines, the types of therapy, the rules, and most importantly, the people. By the end of this series, you will understand the roles, the rhythm, and the reason behind every aspect of an inpatient stay. Whether you're a student, a concerned family member, or someone who might one day need this level of care, this information is designed to replace fear with knowledge. So, let's start with the most fundamental question. Who are the people you will actually interact with every single day? Understanding the cast of characters is the first step to navigating the environment. Think of the unit as a ship navigating a storm. Every crew member has a distinct and critical role. First, you have the captain of the ship, the psychiatrist. This is the medical doctor, the MD or DO, who specializes in mental health. They are the ultimate authority on your treatment plan. They are the ones who diagnose, who prescribe and manage your medications, and who ultimately sign the discharge papers that allow you to go home. Now, here is the first reality check that surprises many people. You will likely see your psychiatrist for maybe 15 minutes a day, sometimes less. This isn't because they don't care. It's because their role is highly specialized and they are often responsible for a dozen or more acutely ill patients. Their short, focused visits are like a surgeon checking on a patient post-op. They are there to make critical assessments and high-level decisions based on the data collected by the rest of the team. They'll ask how the medication is working, if you're having side effects, how you slept, and about your overall mood. Your time with them is brief but incredibly important, so it's vital to be as honest and direct as you can. They hold the keys to the pharmacy and the keys to the front door, making them the most powerful person in your treatment. Next, you have the first mate, the person who runs the ship day to day, the psychiatric nurse. This is typically a registered nurse or RN, and they are the central hub of the entire unit. While the psychiatrist sets the course, the nurse is on the deck, managing the crew and steering the ship through the waves. You will see your nurse constantly. They are the ones who administer your medication at scheduled times, a process known as a med pass. They perform routine health assessments, checking your blood pressure and other vitals. They are also skilled crisis managers. If a patient is escalating or having a panic attack, the nurse is often the first to respond, using de-escalation techniques to ensure everyone's safety. They are the primary person documenting your progress, your behaviors, and your statements in your chart. That chart is what the psychiatrist reads every morning before they come to see you. So, in a very real way, the nurse is your primary communicator to the doctor. Building a trusting, professional relationship with your nurse is one of the most effective things you can do for your own care. They see you at your best and your worst on the unit, and their observations carry enormous weight. Finally, you have the crew that is always present, the boots on the ground, the mental health technicians or MHTs. They might also be called psychiatric aides or behavioral health associates. These are the staff members you will interact with the most, from sunup to sundown. They are the eyes and ears of the unit. Their primary job is to maintain a safe and therapeutic environment for everyone. This means they are constantly observing the patient community, a practice known as milling on the unit. They facilitate group activities, they sit and talk with patients, they might play a game of cards with you, and they are there to listen when you just need to vent. They also handle a lot of the logistical work, taking vitals, documenting what you eat, ensuring you attend your scheduled groups, and conducting safety checks, which can be as frequent as every 15 minutes. This involves physically laying eyes on every single patient to ensure they are safe, even through the night. While they don't administer medication or make diagnoses, their role is profoundly important. They are the ones who see the subtle changes in your behavior. They're the ones who will notice if you're isolating yourself or if you had a positive interaction with a peer. They report all of this information back to the nurses, who then report to the psychiatrist. The technicians form the foundation of the data-gathering pyramid that informs your entire treatment. They are the front line, the most visible and constant presence during your stay. So you have the doctor, the nurse, and the technician, the captain, the first mate, and the crew. These three roles form the core clinical team you'll be working with. But they aren't the only ones. You'll also meet social workers, case managers, therapists, and dietitians, each with a specialized piece of your recovery puzzle. But understanding this core triad is the key to understanding the power structure and the flow of information on any psychiatric unit. They are the system that will guide you from crisis to stability. But knowing the players is only half the story. The real question is, what does a day actually look like? What is the minute-to-minute, hour-to-hour routine that's designed to pull you out of the storm? Because it is a routine, a highly structured, predictable, and often repetitive schedule. And that structure is one of the most powerful therapeutic tools the hospital has. From the moment you wake up, your day is planned. The first sound is often the gentle turning of a doorknob, followed by a soft light spilling in from the hallway. This isn't a jarring alarm clock. It's a check, usually performed by a mental health technician or MHT. These are the frontline soldiers of the psychiatric unit. They're not typically nurses or doctors, but they are the eyes and ears of the entire treatment team. They are with the patients the most, observing interactions, de-escalating tensions, and making sure everyone is safe. They'll do these checks sometimes every 15 minutes all through the night. It's called a Q15 check in hospital slang. And now they are the ones gently rousing you for the day. Your first task is usually a trip to the nursing station for morning vitals. Blood pressure, temperature, pulse. It might seem routine, but it's a critical data point. Is a new medication causing a spike in your blood pressure? Is a low-grade fever a sign of an infection or a side effect? Everything is information. Here you meet another key player, the psychiatric nurse. These nurses are masters of a unique craft. They aren't just administering medication. They're performing a constant, subtle assessment. They're listening to the tone of your voice, watching your body language, asking how you slept. They're cross-referencing that with the MHT's overnight report and the doctor's orders. They are the central hub through which all medical information flows. After vitals, it's often back to your room to get dressed. The clothing you wear was likely inventoried when you arrived. Anything with strings like hoodies or sweatpants has had those strings removed. Belts, scarves, and shoelaces are also gone. This isn't a punishment. It's a fundamental safety protocol called ligature risk reduction. The hospital's primary, non-negotiable goal is to keep everyone alive. Every policy, from the sloped tops of doors to the stringless sweatpants, is designed to eliminate opportunities for self-harm. It's a stark reminder of the stakes involved. Then comes breakfast. Food in a psychiatric hospital gets a bad rap, and sometimes it's deserved. But the act of eating together is in itself therapeutic. It's a communal routine. You're not isolating in your room. You're sharing a space, breaking bread, engaging in the simple human ritual of a meal. You might notice the utensils are plastic. Again, safety is paramount. The MHTs are present, observing the social dynamics. Who is talking to whom? Who is sitting alone? Who isn't eating? This is all valuable information that gets relayed back to the team. Following breakfast is the morning medication line, or med line. This is one of the most important routines of the day. You'll line up at the nursing station window, state your name and date of birth, and the nurse will provide your prescribed morning medications in a small paper cup. You take them with water right there in front of the nurse. They need to see you swallow them. This isn't about a lack of trust. It's about ensuring you're actually receiving the treatment that's been ordered for you. It's a safety check called cheeking, where a patient might pretend to swallow a pill only to save it for later, which can be incredibly dangerous. And who decides on these medications? This brings us to the captain of the ship, the psychiatrist. Now, here's something that surprises many people. You might only see your psychiatrist for about 15 minutes a day. Can feel frustratingly brief. You're in crisis and you get less time with the doctor than you would for a common cold. But you have to understand what's happening behind the scenes. Before that psychiatrist ever walks into the room with you, they've already had a mountain of data compiled for them. They've led a treatment team meeting, the central planning session of the day. In that meeting is the nurse from the floor, the MHT who observed you at breakfast, and another crucial player, your therapist or social worker. The MHT reports on your mood and social interactions. The nurse reports on your vitals, sleep patterns, and any physical complaints. And the therapist or social worker, they're the ones focused on the bigger picture. They're the strategists for your discharge. They talk about your life outside these walls. What's your home situation like? What's your support system? What skills do you need to cope when you leave? They are the ones making calls to your family, coordinating with outpatient services, and planning the roadmap for your recovery journey. So when the psychiatrist finally sits down with you for those 15 minutes, they are armed with a 360-degree view of your last 24 hours. Their questions are incredibly precise and targeted. They're not just asking, "How are you feeling?" They're trying to connect the dots. The nurse said you slept better last night. Does that feel right to you? The MHT mentioned you seemed anxious before breakfast. What was going on then? They are testing hypotheses, adjusting dosages by milligrams, and making high-stakes decisions based on this synthesis of information. Their brief time with you is the surgical strike, not the entire battle. These four roles, the technician, the nurse, the therapist, and the psychiatrist, form the core of your treatment team. They are in constant communication. The MHTs are the ground-level intelligence. The nurses are the medical command center. The therapists are the discharge strategists. And the psychiatrist is the commanding officer, taking all that data and directing the overall clinical plan. This entire structure, this web of roles and routines, is designed to do one thing: create an environment of unconditional positive regard. That's a term from psychology, and it means creating a space where you are accepted and supported, no matter what. The routine provides external order when your internal world is in chaos. The team provides a safety net, catching details and data points you couldn't possibly manage on your own. You don't have to worry about what to eat, when to sleep, or whether you're safe. All of your energy can be focused inward on the difficult work of getting better. And a huge part of that work happens after the morning routine is over. Because once the meds have been passed and the psychiatrist has made their rounds, the day truly begins. The focus shifts from stabilization to therapy. The unit, which was a quiet hum of routine, transforms into a classroom, a workshop, and a forum for profound self-discovery. This is where you learn the tools to rebuild. And it almost always starts with a deceptively simple question, asked in a room full of strangers. So what's our goal for today? That question hangs in the air, thick and uncomfortable. For a newcomer, it feels absurd. A goal? My goal was to not wake up this morning. My goal was to stop the noise in my head. Now you want me to share a neat, tidy goal for today. With a dozen people I've never met? You look around the circle of plastic chairs. There's a young woman, maybe college-aged, staring at a spot on the floor, her leg bouncing like a jackhammer. There's an older man with the haunted, distant eyes of a combat veteran. There's a well-dressed man who looks like he should be in a boardroom, not a linoleum-floored day room, and he just keeps clenching and unclenching his fists. Everyone is fighting a war you can't see. And in the middle of it all is the group therapist. It's important to understand this person is rarely a psychiatrist. They're usually a licensed clinical social worker, a marriage and family therapist, or a licensed professional counselor. Their job isn't to prescribe medication. Their job is to guide this strange, fragile gathering. They aren't a lecturer. They're a facilitator. They hold the space, keeping it safe enough for the raw, unfiltered truth to tentatively emerge. Someone finally breaks the silence. A young man with track marks on his arms says his goal is to get through the day without thinking about using. The therapist nods. Okay. What's one small thing you can do to help with that? He thinks for a moment. Maybe talk to someone when the craving hits. Simple. Actionable. It's not a magic cure, but it's a plan. It's a foothold. Slowly others start to share. My goal is to eat my lunch. My goal is to call my sister. My goal is to figure out why I'm so angry. And you realize the power of this exercise isn't in achieving some grand objective. It's in the act of articulating a single manageable step forward. It's the first lesson in a psychiatric unit. You have to shrink the world down to a size you can handle. The next 24 hours becomes the next hour, which becomes the next 5 minutes. And sometimes the goal is simply to get through those 5 minutes. This is the rhythm of the ward. It's a highly structured world, designed to replace chaos with predictability. Your day is broken into blocks, almost like a school schedule. After the morning goal-setting group, you might have something called psychoeducation. This is essentially a class. The topic might be understanding depression, the role of medication, or coping with anxiety. A therapist stands in front of a whiteboard and explains neurotransmitters, serotonin, and dopamine. They talk about sleep hygiene, nutrition, the importance of a routine. For many, it's the first time they've ever been given a user's manual for their own brain. It's the why behind their illness, and that knowledge in itself can be a powerful anchor. Then comes the real heavy lifting, skills-based groups. This is where you find the alphabet soup of modern therapy, CBT and DBT. Cognitive behavioral therapy, or CBT, is built on a revolutionary idea. Your thoughts are not facts. The therapist might put a simple diagram on the board, a triangle connecting thoughts, feelings, and behaviors. They explain how a negative thought, "I'm a complete failure," leads to a feeling of hopelessness, which leads to the behavior of staying in bed all day. The group then learns to become detectives of their own minds. They learn to identify those automatic negative thoughts, to challenge them, to ask, "What's the evidence for that? Is there another way to look at this?" You practice it right there in the room. Someone shares a thought like, "My boss emailed me, he must be mad at me." And the group, guided by the therapist, helps them reframe it. What else could it be? Maybe he's just following up. Maybe he needs information for a project. It sounds simple, almost insultingly so, but when your brain's default setting is catastrophe, learning to consciously choose a more neutral thought is like learning to breathe underwater. Then there's dialectical behavior therapy, or DBT. If CBT is about changing your thoughts, DBT is about accepting them and learning to survive the intense emotions they cause. This is emotional first aid. It's for the moments when your brain is on fire and you can't think your way out of it. You learn skills for distress tolerance. One of the most famous is called TIP. Temperature, intense exercise, paced breathing, and paired muscle relaxation. The therapist explains it. When you feel a wave of panic or rage coming, you can literally change your body's chemistry. Go splash ice-cold water on your face. The shock triggers the mammalian diving reflex, slowing your heart rate. Do jumping jacks or push-ups for 60 seconds until you're out of breath. The physical exertion burns off the adrenaline. You learn to breathe in for 4 seconds, hold for 4, and exhale for 6, calming your nervous system. You learn to clench every muscle in your body for 10 seconds and then release, forcing your body to relax. These aren't just ideas. They are physical tools you can use when your mind is screaming. In between these intense sessions, there's another key player you see constantly. The mental health technician, or MHT. They don't run therapy groups, but they are the lifeblood of the unit. They're the ones taking your vital signs at 6 a.m. They're the ones sitting with you in the day room, playing a game of cards or just making small talk. They're the ones who do the 15-minute checks, a constant silent patrol to ensure everyone is safe. They are the eyes and ears for the nurses and doctors. They see who is isolating, who seems agitated, who isn't eating. They de-escalate situations before they explode, using a calm voice and quiet presence to soothe a rising tide of panic or anger. They are observers, caregivers, and security, all rolled into one, and they often form the most consistent human connection you have throughout the day. The routine is punctuated by the med window. 2 or 3 times a day, a line forms at the nurse's station. You state your name and date of birth. A nurse checks your photo on a screen, finds your prescriptions, and drops a few small pills into a tiny paper cup. You take them with a sip of water as they watch, and then you have to open your mouth and lift your tongue to show you've swallowed them. This ritual is non-negotiable. It's a stark reminder that this is a medical facility, and that your brain, like any other organ, sometimes requires medication to heal. For some, this is a moment of hope, the belief that this tiny pill might finally quiet the storm. For others, it's a moment of surrender, a concession to an illness they still don't fully understand. The day might end with something softer. Art therapy, maybe. The prompt could be, draw what your depression feels like. A skeptical part of you might scoff. How can crayons and paper fix a broken mind? But then you see that big, tough veteran, the one who hasn't spoken a word all day, hunched over his paper, meticulously drawing a tangled knot of black and red scribbles. You see the college student, the one with the bouncing leg, paint a beautiful, serene landscape, but with a tiny, terrified figure hiding in the corner. You realize it's not about creating a masterpiece. It's about giving a shape and color to something that feels shapeless and invisible. It's a way of speaking when words fail. And in a room full of people who feel profoundly misunderstood, seeing your own internal chaos reflected on someone else's paper is a powerful, unspoken form of connection. You're not just a collection of symptoms in a clinical file. You're a person with a story, even if you can only tell it in color and shadow. This is the work. It's slow, it's repetitive, and it's exhausting. But piece by piece, group by group, skill by skill, the structure of the ward starts to build a scaffold where a shattered mind can begin to piece itself back together. It's not just about surviving the crisis that brought you here. It's about learning an entirely new way to live. But you don't learn that new way to live in a vacuum. That scaffold we talked about? It's not self-assembling. It's built by a team of highly specialized, often misunderstood, and incredibly dedicated people. When the doors lock behind you, these are the faces you will see every single day. They are the architects, the engineers, and the construction crew of your recovery. And understanding their roles is critical to understanding how a psychiatric ward actually functions. So who are these people? Are they guards, therapists, medics? The truth is, they're a little bit of all of those things, a complex human ecosystem designed for one purpose: to pull you back from the brink. Let's start with the person you'll interact with the most, the one whose presence defines the minute-to-minute reality of the unit. They're called mental health technicians, or MHTs. Sometimes psychiatric technicians or aides. Think of them as the non-commissioned officers of the ward. They don't have advanced medical degrees, but their experiential knowledge is vast, and their role is indispensable. They are the eyes and the ears of the entire clinical team. They are present for every meal, every group, every smoke break. They're the ones doing the 15-minute checks, glancing into your room to ensure you're safe, a constant quiet rhythm of reassurance. They're the ones who will sit and play a game of cards with you when you're feeling isolated, or gently coax you out of your room to attend a group you'd rather skip. They are masters of observation. They notice the patient who is starting to isolate, the one whose personal hygiene is slipping, the subtle shift in tone between two patients that might escalate into a conflict. They document everything. Every small detail, every conversation, every refusal of a meal gets logged. This constant stream of data is the lifeblood of the treatment plan. The psychiatrist, who you might only see for 10 minutes a day, relies heavily on the 24 hours of observation provided by the MHTs. They are also the front line of crisis response. When a patient becomes agitated or aggressive, it's the techs who are trained in de-escalation, who use their words and their presence to bring the temperature down before a crisis erupts. They are the bedrock of the unit's stability. Next up the chain of command, you have the psychiatric nurses. These are registered nurses, or RNs, who have specialized in mental health. If the techs are the eyes and ears, the nurses are the central nervous system of the ward. They are the medical authority on the floor. Their most visible job is medication administration, the famous med pass. Several times a day, a line forms at the nurse's station, a window slides open, and patients receive their prescribed medications in a small paper cup. But this is just the tip of the iceberg. A psychiatric nurse is a master assessor. They are constantly evaluating not just your mental state but your physical health. Are the side effects of a new antipsychotic causing tremors? Is a patient's agitation a symptom of their bipolar disorder? Or could it be a urinary tract infection causing delirium? They are trained to see the intricate connections between the mind and the body. They field calls from concerned family members, provide education on medications, and manage the complex dance of PRN, or, as needed, medications for anxiety or agitation. They are the ones who will sit with you when you're overwhelmed by side effects, explaining what's happening to your body and reassuring you. They are the direct line of communication to the psychiatrist, reporting any significant changes, advocating for adjustments in your treatment, and carrying out the doctor's orders. Their clinical judgment is a critical firewall that keeps patients safe. Then you have the social worker or case manager. This is perhaps the most outwardly focused role on the team. While everyone else is concentrating on stabilizing you inside the hospital, the social worker is already planning your escape. From the moment you are admitted, their goal is your successful discharge. They are the bridge to the world you left behind and the world you will return to. They are logistical wizards. They ask the tough questions. Where will you live? Do you have a job to go back to? Is your home environment safe? What is your insurance situation? They are the ones who will call your family to arrange a family therapy session, acting as a mediator to help repair relationships and educate your loved ones on your condition. They connect you with outpatient resources, a therapist, a psychiatrist, a partial hospitalization program so that your care doesn't just stop the second you walk out the door. This is one of the most vital functions of the entire hospital stay. Without a solid discharge plan, the odds of relapse and readmission skyrocket. The social worker is your advocate, your navigator, your strategist, fighting to ensure that the stability you gain on the inside has a fighting chance of surviving on the outside. Of course, what about the therapy itself? This is the domain of the therapists and psychologists. They are the ones who run the group sessions we talked about, the DBT, the CBT, the art therapy. They are the teachers, providing the concrete skills and psychoeducation that form the learning part of your stay. They might be a licensed clinical social worker, a marriage and family therapist, or a PhD-level psychologist. In some hospitals, you may be assigned an individual therapist who you meet with a few times a week. This is where you can do the deeper work to process the specific trauma or crisis that led to your hospitalization. Unlike the psychiatrist, their focus isn't on medication. It's on cognition, behavior, and emotion. They help you connect the dots, to understand your triggers, to reframe your negative thought patterns, and to practice the coping skills you're learning in group. If the MHTs provide the stability and the nurses provide the medical care, the therapists provide the tools for mental reconstruction. And finally, at the top of this pyramid, you have the psychiatrist, the MD, the doctor. They are the captain of the ship, the final authority on your treatment plan. The modern psychiatrist in an inpatient setting is not the Freudian analyst you see in movies, sitting in a leather chair while you recline on a couch. Their role is primarily that of a psychopharmacologist, a medical expert in the brain and the powerful medications that can alter its chemistry. You will likely see the psychiatrist once a day, usually in the morning during what are called rounds. This can be a surprisingly brief interaction, sometimes only 5 or 10 minutes. This brevity can be frustrating for patients who feel like they barely have time to explain what's going on. But you have to remember, the psychiatrist is not starting from zero. Before they even walk into your room, they have read the overnight reports from the techs, reviewed the nursing assessments, consulted with your social worker about discharge planning, and talked to your therapist about your progress in group. That 10-minute conversation is the final data point in a vast network of information. They are synthesizing everything. Their job is to make the big-picture medical decisions, to diagnose your condition, to select the right class of medication, to titrate the dosage up or down, and to manage the delicate balance between therapeutic effect and debilitating side effects. They carry the ultimate legal and medical responsibility for every patient on the unit. Techs, nurses, social workers, therapists, and doctors. Each has a distinct role, a different lens through which they view your crisis. But together they form a web of support, observation, and intervention. It is this multi-layered, collaborative approach that makes an inpatient unit more than just a place of containment. It's a crucible for change, a workshop where a team of specialists comes together, each bringing their unique tools to the monumental task of helping you rebuild. They work together, they communicate, they debate your case in treatment team meetings, all focused on a single shared goal: to get you well enough to walk back out those locked doors, not just as the person you were, but as someone with a new set of plans, a new set of skills, and a new chance. So, who exactly are the people on this team? Who are the faces you'll see every day? The voices you'll hear in those meetings, the hands that will guide you through this process. It's not just a random collection of staff. It's a highly specialized unit, a sort of psychological special forces, and each member has a distinct and critical role in your recovery. Understanding who does what is one of the most powerful tools you can have, because it demystifies the entire experience. It turns a confusing and often intimidating environment into a structured system with a clear purpose. Let's start at the top of the pyramid, the psychiatrist. Think of the psychiatrist as the architect of your treatment plan. They are the medical doctor, the MD, who holds the ultimate responsibility for your care. Their primary focus is on the biological and neurological aspects of your condition. They are the diagnosticians. They'll listen to your story, review your history, observe your symptoms, and put a name to what you're experiencing, whether it's major depressive disorder, bipolar disorder, schizophrenia, or an acute psychotic episode. This diagnosis is the blueprint. It's what informs every other decision that follows. Their most visible and powerful tool is medication. The psychiatrist is the one who prescribes, adjusts, and manages your psychotropic medications. This is a process of careful, educated trial and error. What works wonders for one person might do nothing for another, or might come with intolerable side effects. Your daily interaction with the psychiatrist will likely be brief, maybe just 5 to 10 minutes a day during what's called rounds. This can be frustrating for patients who expect a long, deep conversation, but it's important to understand their function. They are laser-focused on assessing your response to the treatment plan. They'll ask targeted questions. How did you sleep? Are you hearing the voices? How is your energy level? Are you feeling any side effects from the new medication? Dry mouth? Restlessness? Drowsiness? This is your moment to be a precise and honest reporter of your own internal state. That short interaction is incredibly data-rich for them. Every piece of information you give helps them fine-tune the blueprint. They are the captain of the ship, steering the overall direction of your medical treatment. They lead the treatment team meetings, synthesize the information from all the other staff, and make the final call on major decisions, including the one everyone is waiting for, the decision that you are stable enough for discharge. Next, you have the therapist, or, in many cases, the social worker. If the psychiatrist is the architect, the therapist is the navigator and your chief advocate. This is the person you'll likely spend the most one-on-one time with, in sessions that last 30 to 60 minutes. While the psychiatrist is focused on the what, the diagnosis and the medication, the therapist is focused on the why and the how. Why did you end up here? What are the underlying issues, the traumas, the patterns of thinking and behaving that led to this crisis? And most importantly, how are you going to manage them differently when you leave? This is where the deep work happens. In individual therapy, you'll explore your personal history. You'll learn coping mechanisms through modalities like cognitive behavioral therapy, or CBT, which helps you identify and challenge distorted thoughts, or dialectical behavior therapy, DBT, which teaches skills for emotional regulation and distress tolerance. The therapist is also often the one who runs the group therapy sessions, which are a cornerstone of inpatient treatment. They facilitate discussions on topics like anger management, grief, communication skills, and relapse prevention. But their role extends far beyond therapy. They are your connection to the outside world. They are the primary contact for your family, arranging family meetings to educate your loved ones and plan for your return home. And critically, they are the discharge planner. From the moment you are admitted, they begin working on your exit strategy. What does life look like after the ward? Do you have a safe place to live? Do you have an outpatient therapist and psychiatrist lined up? Do you need to be connected with housing resources, vocational rehab, or substance abuse programs like AA or NA? The therapist builds your bridge back to the world, ensuring you don't just walk out the door and fall right back into the same situation that brought you in. They are your voice in the treatment team meeting, advocating for the resources and support you'll need to succeed. Then you have the backbone of the unit, the nursing staff, the registered nurses or RNs and licensed practical nurses or LPNs. If the psychiatrist is the architect and the therapist is the navigator, the nurses are the frontline commanders. They are the ones executing the treatment plan minute by minute, 24 hours a day. They are a constant presence on the floor, and you will interact with them more than anyone. Their most obvious role is medication administration. Several times a day, you'll hear the call for meds, and you'll line up at the nursing station, state your name and date of birth, and receive your prescribed medications in a small paper cup. But their job is infinitely more complex than that. They are highly skilled observers, constantly assessing the milieu, the overall mood and safety of the unit. They monitor your vital signs, track your sleep and appetite, and document your behavior and mental state in meticulous detail. They are educators teaching you about your diagnosis and your medications, what they're for, how they work, and what side effects to watch for. They are also crisis managers. When a patient becomes agitated, aggressive, or is a danger to themselves, it is the nursing staff who are trained to step in, using de-escalation techniques to calm the situation. They are the first responders to any medical or psychiatric emergency on the unit. They embody a difficult duality. They are caregivers, there to offer a supportive word and a listening ear, but they are also the enforcers of the rules, the ones who ensure the safety and structure of this highly controlled environment. Finally, there's a group of staff you'll see constantly walking the halls, sitting in the day room, and interacting directly with patients. These are the mental health technicians, or MHTs, sometimes called psychiatric aides or behavioral health specialists. Think of them as the eyes and ears of the unit. While the nurses are often busy with medical tasks, the techs are embedded with the patients. Their primary job is observation and safety. They are the ones performing the 15-minute checks, visually locating every single patient on the unit 4 times an hour, day and night, to ensure their well-being. But they are so much more than just observers. They are the foot soldiers of the ward. They often co-facilitate therapy groups, run activities like art or music therapy, and assist patients with basic activities of daily living. They are the ones you'll sit and play a card game with, the ones who will walk with you in the courtyard, the ones you'll talk to when you're feeling anxious or lonely in the middle of the afternoon. Because their interactions are often more informal, patients frequently build the strongest rapport with the techs. And what they see is absolutely vital. They see how you interact with your peers when no one with a clipboard is watching. They see if you're isolating in your room or participating in the community. They hear the casual comments you make that might reveal your true state of mind. All of this information is charted and reported back to the rest of the team. The small observation a tech makes during a card game can be the key piece of information the psychiatrist uses to make a medication change. Together, this entire team, the architect, the navigator, the commanders, and the eyes and ears, creates a 360-degree view of your progress, all working in concert. They form a web of support, observation, and intervention. Now that you know the players on the field, what does the game actually look like? What is the daily rhythm and routine of life inside these walls? Because it's not random. From the moment you're woken up until the moment you're locked in for the night, every single day is built around a rigid, predictable, and therapeutic schedule. And that schedule begins with the one sound you can never escape on the unit: the overhead lights buzzing on and a voice announcing the start of a new day. That announcement, often delivered by a mental health technician over a crackling intercom, is the universal starting gun. There's no snooze button here. For everyone, from the patient who slept soundly for the first time in weeks to the one who stared at the acoustic ceiling tiles all night, the day has officially begun. The first 30 minutes are a blur of shared groggy reality. Doors to patient rooms, which may have been locked overnight for safety, are unlocked. The low hum of conversations begins in the day room as people slowly emerge, shuffling in hospital-issued non-slip socks. But the first order of business isn't breakfast. It isn't a shower. It's vitals. Before anything else, the medical reality of the unit asserts itself. A nurse or a tech, armed with a rolling cart, goes from room to room or calls patients to a small triage station. Blood pressure cuff, thermometer, pulse oximeter on the finger. They ask a simple question: how did you sleep? But they're looking for more than a one-word answer. They're observing. Are your eyes clear or bloodshot? Is your speech slow and slurred or rapid and pressured? Are you making eye contact? Every small interaction is an assessment, a piece of data for the larger clinical picture. Then comes the centerpiece of the morning routine, a ritual as ingrained in the psychiatric unit as the rising sun, the med line. A window slides open at the nurse's station, and a line begins to form. This isn't a chaotic rush. It's a slow, deliberate process. One by one, patients step up to the window. They state their full name and date of birth. This isn't just a formality. It's a critical safety check and a small cognitive test. Can the patient orient themselves enough to provide this basic information? Inside the station, the nurse is the master of this domain. This is where their meticulous training in pharmacology and patient safety shines. They consult the Medication Administration Record, or MAR, a document that is the absolute Bible of the patient's treatment. They cross-reference the doctor's orders with the patient's name, allergies, and the specific medications scheduled for that time. Then they begin the process of pulling meds. Pills are popped from blister packs into a tiny paper or plastic cup. Each pill has a purpose. That small white one might be a mood stabilizer to even out the dangerous highs and lows of bipolar disorder. The little blue one could be an SSRI, an antidepressant slowly working to rebalance serotonin levels. The larger capsule might be an antipsychotic, helping to quiet terrifying hallucinations or break the grip of paranoid delusions. And that other one might be for a physical condition because mental illness doesn't make diabetes or high blood pressure disappear. The nurse presents the cup to the patient, explaining what each medication is and what it's for. Here is your lamotrigine for mood, your Seroquel for sleep and psychosis, and your lisinopril for blood pressure. This isn't just about dispensing. It's about education and consent. The patient is expected to take the pills right there at the window with a cup of water. And then they have to do something that feels strange to the outside world. They have to open their mouth. The nurse will often ask them to lift their tongue and move their cheeks. They're checking to make sure the medication was actually swallowed, a practice known as a mouth check. This isn't about mistrust. It's a safety measure. Some patients, in the depths of their illness, may be cheeking their meds, hiding them in their mouth to spit out later. They might do this because their paranoia tells them the pills are poison, or because they intend to save them up to overdose later. The mouth check prevents this. It ensures the treatment is actually being delivered. Once the medline is complete, the unit transitions to the next phase. Breakfast. Meals on a psychiatric unit are a study in controlled environments. The food is served cafeteria style on section trays. There's no metal silverware. Everything is plastic or, in some cases, a flexible spork to minimize any risk of self-harm or harm to others. There are no glass cups or plates. Even salt and pepper might be in single-serving paper packets to prevent them from being thrown. Staff members are always present in the dining area, not just to supervise but to observe. Meal times are incredibly revealing. Is a patient with severe depression eating at all? Is a patient with mania too agitated to sit down and finish their meal? Is a patient with an eating disorder just pushing food around their plate? Are patients isolating themselves, or are they engaging in conversation? This social dynamic is a key indicator of progress. After breakfast, the work of the day begins, and it starts with the morning meeting or goal-setting group. Everyone gathers in the day room, pulling the heavy, weighted plastic chairs into a large circle. This is typically led by a therapist, a licensed clinical social worker, or an occupational therapist. The structure is simple but profound. Going around the circle, each patient is asked to introduce themselves and state their goal for the day. For someone whose life has been shattered by mental illness, this can be an incredibly difficult task. A goal might be as simple as, "I'm going to take a shower today." For someone with depression so severe that basic hygiene feels impossible, it might be, "I'm going to talk to one new person." For someone crippled by social anxiety, for a patient struggling with psychosis, the goal might be, "I'm going to use one coping skill I learned to challenge my negative thoughts." The therapist doesn't just listen, they facilitate. They help patients reframe unrealistic goals. If a patient says, "My goal is to get discharged today," the therapist might gently guide them towards something more immediate and controllable, like, "That's a great long-term goal. What's one small step you can take today that moves you closer to being ready for discharge?" This process serves multiple functions. It imposes structure on a mind lost in chaos. It creates accountability, as the group will often check in at the end of the day to see if goals were met. And most importantly, it fosters a sense of agency. It's a declaration spoken out loud in a community of peers that you are not just a passive recipient of treatment. You are an active participant in your own recovery, and it starts with one single achievable goal for the next few hours. This morning meeting sets the therapeutic tone for the entire day. It shifts the focus from the passive acts of taking meds and eating meals to the active work of recovery. And as that meeting concludes, a different kind of anticipation begins to build on the unit. The groups and activities are important, but everyone knows the most crucial interactions are the individual ones. Specifically, the one-on-one time with the person who manages the entire treatment plan, the person who holds the power to change medications, grant privileges, and ultimately sign the discharge papers. The morning schedule is deliberately structured to lead up to this moment. The daily check-in with the team's leader, the psychiatrist. When the psychiatrist walks onto the unit, the entire atmosphere shifts. It's a subtle change, not a dramatic one, but you can feel it. The ambient chatter quiets down. The nurses and techs move with a renewed sense of purpose. Patients who were pacing the halls suddenly find a reason to be near their rooms. This isn't just another staff member. This is the architect of your immediate future. They are the final word. The process is called rounding, and it's a core ritual of inpatient psychiatric care. It sounds formal, almost grand, but the reality is often a blur of managed efficiency. The psychiatrist, often accompanied by a nurse or a resident, moves from door to door, a clipboard or a tablet in hand. They are on a schedule, a very tight one. They might have 15, 20, even 30 patients to see in the span of a couple of hours. Do the math. That's not a deep therapeutic conversation. That's a high-speed, high-stakes check-in. Maybe 10 minutes if you're lucky. Sometimes it's closer to 5. Imagine having just 5 minutes to convince someone you are sane enough to be free. 5 minutes to summarize the chaotic symphony of your mind into a few coherent, acceptable sentences. What do you say? How do you package a night of terror, or a morning of profound, soul-crushing emptiness, into a soundbite that won't get you another week on the unit? This is the game every patient learns to play. You rehearse your lines in your head. You wake up and the first thing you think is, "What am I going to tell the doctor today?" You perform a self-assessment, not for your own benefit but for theirs. Okay, I slept 6 hours. That's good. I should lead with that. I ate most of my breakfast. Mention that too. I went to group yesterday. Check. You're building a case for your own sanity piece by piece. But then there are the landmines. What about the fact that you woke up crying for no reason? Or that the new medication makes your hands tremble so much you can barely hold a fork? Do you mention that? If you do, it might sound like a complaint, like you're non-compliant or treatment resistant. They might see it as a new symptom, a setback. They might change the medication, resetting the clock on your recovery, adding weeks to your stay while you wait to see if the new pills work. So maybe you don't mention it. You hide your shaking hands under the table and you force a smile. You say, "I'm feeling a little better today, doc. I think the meds are starting to help." Every word is weighed. Every facial expression is calculated. You become an actor in your own life, playing the part of the good patient. You learn to use the right language. You talk about developing coping skills and identifying triggers. You parrot back the phrases you heard in group therapy, hoping they land as signs of progress. You are desperate to show them you are getting better, even if on the inside you feel like you're falling apart. From the psychiatrist's perspective, this is a monumental challenge. They are not unfeeling or uncaring. They are detectives trying to solve a complex mystery with only a handful of clues and a ticking clock. They know that what the patient presents in those 5 minutes is a performance. Their job is to see through it. They are looking at your body language. Are you making eye contact? How is your hygiene? Is your speech pressured and fast or slow and delayed? They are listening not just to what you say but how you say it. They've already reviewed your chart. They've read the overnight nurse's notes detailing whether you slept, if you were agitated, if you refused your meds. They've seen the report from the therapist about your participation in group. They are synthesizing all of this data in real time. So when they ask, "How are you feeling today?" it's not just a pleasantry. It's a diagnostic question. They are comparing your answer to all the other information they have. If you say, "I'm feeling great 100%, but the overnight nurse noted you were up all night pacing and crying," that's a red flag. The discrepancy is more telling than the words themselves. The primary tool of the psychiatrist on an inpatient unit is psychopharmacology, medication. Those 5 to 10 minute check-ins are largely about medication management. Is the current dosage working? Are the side effects tolerable? Does it need to be increased, decreased, or changed entirely? It's a process of careful, educated guesswork. Psychiatry isn't like treating a bacterial infection where you can identify the specific pathogen and prescribe a targeted antibiotic. The brain is infinitely more complex. It's more like, "Let's try this key in this lock and see if it turns." No? Okay, let's try another key. For the patient, this can be agonizing. You're given a new pill with a list of potential side effects a mile long, from weight gain to emotional numbness to muscle tremors. And you're told to wait. Wait too, for even 6 weeks for it to reach its full therapeutic effect. Living in that waiting period is its own special kind of hell. Every day you wake up and wonder, is this the day it starts working? Do I feel different? Am I less anxious? Am I less depressed? Sometimes the side effects arrive long before any relief does, and you're left to wonder if it's even worth it. After the whirlwind of rounding is complete, the psychiatrist disappears behind the locked doors of the nurse's station for the most important meeting of the day, the team meeting. This is where all the pieces come together. The psychiatrist leads the meeting, but everyone who has interacted with the patient has a voice. The social worker discusses family dynamics and discharge planning. The therapist shares insights from individual and group sessions. The nurses provide the crucial 24/7 observations: who is isolating in their room, who is having conflicts with peers, who ate all of their lunch, who had a panic attack at 3 a.m. This is where the holistic picture of the patient is formed. The psychiatrist might say, "John told me he's feeling much better and ready to go home." And the nurse might reply, "That's interesting because he refused to shower this morning and got into a shouting match with another patient over the TV remote." That single piece of information from the nurse completely changes the context of John's self-report. It's in this meeting that the daily plan for each patient is solidified. Medication adjustments are finalized. Privileges are discussed. Can a patient be upgraded from unit restrictions to being allowed escorted grounds access? Is someone stable enough for a weekend pass to go home? And the biggest question of all, who is ready for discharge? The decisions made in that room ripple out across the unit for the rest of the day. A tech will approach a patient and say, "Good news, the doctor approved you for grounds privileges. We can go for a walk outside after lunch." For that patient, it's a monumental victory, a tangible sign of progress, the first breath of fresh air in weeks. For another, the news is less encouraging. The team wants to observe you for a few more days on the new medication before we discuss discharge. It's a crushing blow, a delay that can feel like a life sentence. The plan, delivered by a nurse or a tech, becomes the reality you have to live with, a direct consequence of that brief morning interaction and the secret meeting that followed. It sets the tone for the entire day, dictating whether you feel a flicker of hope or the heavy weight of despair. And so you sit with that decision. It's not a piece of paper handed to you, but an invisible brand on your forehead that only the staff can see. It changes the way the nurse looks at you when she hands you your mid-morning meds. It alters the tone the mental health tech uses when he tells you it's time for group. You are now officially categorized for the next 24 hours, making progress, at risk, or worst of all, no change. The day's main event, its central pillar, is group therapy. You're herded into a sterile room with a circle of mismatched, uncomfortable chairs. This is the arena where you're expected to be vulnerable on demand. The air is thick with a mixture of stale coffee, disinfectant, and unspoken trauma. A therapist, often young and armed with a relentlessly positive attitude and a clipboard, sits in the circle with you. They start with a check-in. On a scale of 1 to 10, how's your mood today? And what's one goal you have for this session? You listen as it goes around the circle. A man in his 60s, shaking from detox, mumbles a 3. A young woman with faded scars lining her arms says, a 4 I guess, and stares at a spot on the floor. Someone else, manic and bright, declares they're a solid 9. And their goal is to help everyone else see the beauty in the universe. You have to calculate your own answer. Too low, and you're seen as uncooperative or treatment resistant. Too high, and they'll think you're masking your issues or lack insight. You settle on a safe, neutral 5. Your goal? To listen. It's the perfect non-answer. It sounds participatory without requiring you to actually reveal anything. The topic of the day is announced. It's usually something frustratingly generic. Identifying cognitive distortions. Developing healthy coping skills. The importance of a gratitude practice. You're handed a worksheet. The therapist talks about black and white thinking, or catastrophizing. To you, it feels like a high school health class trying to explain a war zone. You're not catastrophizing. Your life is a catastrophe. You're not thinking in black and white. You're living in a world that has lost all its color. But you watch the other patients. Some desperately cling to these concepts, writing furiously on their worksheets, as if the words themselves hold a magic key. Others are masters of performance. They share a perfectly packaged anecdote about how they used a coping skill yesterday, earning a nod of approval from the therapist. This is the currency of the ward, perceived progress. Then there are the ones who refuse to play. They sit, arms crossed, radiating contempt, or they challenge the therapist, deconstructing the flimsy logic of the worksheet with a terrifying, brilliant clarity that only comes from having lived through the things the therapist has only read about. These moments are electric. The tension skyrockets. The staff in the room shift their weight, their hands inching closer to the walkie-talkies on their belts. Sometimes, though, against all odds, a moment of real connection happens. Someone shares a story so raw, so honest, that the entire artifice of the session collapses. For a fleeting minute, you're not just a collection of diagnoses in a room. You're human beings united by a shared profound pain. You see your own struggle reflected in a stranger's eyes, and in that moment, you feel less alone. These moments are rare, like finding a diamond in a landfill, but they're what keep you showing up. They're the reason you don't just walk out. Well, that and the fact that the door is locked. After group, there's a vacuum of time before lunch. This is when the social hierarchy of the unit solidifies. You see the cliques form. The addicts tend to stick together, speaking a shared language of recovery and relapse. The patients with severe depression form a quieter constellation, often communicating with no more than a shared, weary glance. The younger patients, full of restless energy, might be trying to organize a card game with a deck that's missing half the jacks. You have to find your place or risk being an outcast, which is a dangerous thing to be in a place where you are under constant observation. Then comes lunch, the highlight and the lowlight of the day. You line up, grab a plastic tray, and slide it down the metal counter. The food is institutional in every sense of the word. It's beige, it's lukewarm, and it has a texture that suggests it was cooked hours, maybe days ago. But it's a break in the monotony. It's a sensory input that isn't fluorescent light or the smell of bleach. The dining room is a theater of social anxiety. Where do you sit? Sitting alone marks you. Sitting with the wrong group can be just as bad. Every interaction is scrutinized by the staff. They chart everything. Did you eat all your food? Did you talk to anyone? Did you laugh? It all goes into the file, another data point in the algorithm that will determine your fate. You learn to eat mechanically, to make small talk that reveals nothing, to look engaged but not too happy, sad but not too sad. It's a tightrope walk over a pit of misinterpretation. The afternoon is the longest, hardest part of the day. It's a vast, empty desert of time. The structured activities are over. There might be an art therapy session, which consists of sitting at a table with some dried-up markers and copy paper, or recreation time, which means you can walk up and down the same 20-foot hallway. More often than not, it's just nothing. This is when the real illness, the one that doesn't have a name in the diagnostic manual, sets in. A profound, soul-crushing boredom. You find yourself in the day room. A giant, outdated television is bolted to the wall, perpetually tuned to a game show or a soap opera. The sound is tinny, the colors are faded. People who were strangers a week ago now argue with the familiarity of siblings over the remote control. The same puzzles with missing edge pieces are scattered on a table. The same dog-eared books with broken spines sit on a shelf. You watch the clock. The slow, merciless tick of the second hand is the only thing that proves time is actually moving forward. You might pace the hallway, counting your steps until you've worn a path in the linoleum. You might sit by the reinforced window, staring at a sliver of the outside world. A tree, a parking lot, a piece of sky, and feel a longing so intense it's a physical ache. This is the time when the walls feel like they're closing in, when the reality of your confinement becomes suffocating. This is when you have to fight your own mind the hardest, because in the absence of any external stimulation, it will turn on itself. The mental health techs, the MHTs, are the wardens of this afternoon purgatory. They're not therapists. They're mostly there for safety and observation. They sit at their station behind a thick pane of plexiglass, charting, watching, and waiting. They are the ones who break up the arguments, who tell you to take your feet off the furniture, who lead the 15-minute checks, peering into your room to make sure you're still there, still breathing. Your relationship with them is complex. They hold all the power. They can grant you a blanket, allow you an extra phone call, or they can write a negative note in your chart that could set your progress back for days. You learn which ones are kind, which ones are jaded, and which ones are on a power trip. You learn to be polite, to be small, to not make waves. And then, just as the afternoon sun begins to cast long shadows across the floor, a shift happens. Literally. The 3 o'clock shift change. The day staff, with their familiar faces and predictable routines, begin to pack up. The evening staff arrives. A new energy floods the unit. They huddle at the nursing station for report, and you know you're being discussed. Your entire day, the number you gave in group, what you ate for lunch, the fact you paced the hall for an hour, is condensed into a 2-minute summary. You are reduced to a verbal footnote. And as this new team of strangers takes over, you have to recalibrate everything. The rules might be subtly different, the personalities are unknown. The fragile sense of stability you've built over the last 8 hours is shattered, and the whole terrifying process of survival has to begin all over again, just as darkness begins to fall outside. And with that shift change, the entire ecosystem of the ward is thrown into disarray. The air itself seems to change, growing heavier as the fluorescent lights take on a harsh, artificial glare against the darkening windows. This is the liminal space, the transition from the structured, therapeutic chaos of the day to the unstructured, internal chaos of the night. For many patients, especially those with cognitive impairments, dementia, or severe anxiety, this is the beginning of sundowning. The fading light outside triggers a primal increase in confusion, agitation, and fear. The familiar faces of the day shift staff, the ones whose rhythms and expectations you just spent 8 hours learning, are gone. In their place are strangers. The evening staff often have a different energy. They're coming in fresh while the patients are hitting a wall of emotional and physical exhaustion. They have their own way of doing things, their own personalities to navigate. The head nurse for the evening might be stricter about phone time, or perhaps more lenient about letting patients stay in their rooms. The mental health techs might organize a movie night, or they might be more focused on paperwork, leaving the community room to descend into a quiet, simmering tension. You have to learn the new rules fast. You have to reevaluate who might be an ally, who might be a threat, and who you need to avoid. It's a high-stakes social recalibration that your exhausted mind is in no shape to handle. Dinner is served. It's often the same rotation of food, another anchor of mundane routine in a sea of unpredictability. But eating is a challenge. For some, the medication has stolen their appetite. For others, the depression makes the act of lifting a fork feel like a monumental effort. And for those with paranoia, every meal is a potential threat. Scrutinize for any sign of tampering. You sit at the plastic tables, under the watchful eyes of the staff, trying to force down food while navigating the complex social dynamics. The person who was catatonic this morning might now be manic, talking a mile a minute. The person who was your quiet confidant in group therapy might now be glaring at you from across the room, lost in a delusion you can't comprehend. The fragile truce of the daytime often evaporates with the sun. After dinner comes the second major medication pass of the day. This one is critical. It often includes the sedatives and sleep aids prescribed to help patients get through the night. The line forms again. A silent procession of people waiting for the small paper cup that holds the key to a few hours of potential peace. For many, this medication is the only hope of escaping their own minds, even if just for a little while. It's a chemical ceasefire. But it also marks a point of no return for the evening. The doors are locked. The connection to the outside world is about to be severed. This is when evening visiting hours typically end, and it's one of the most painful moments of the day. Family members and loved ones say their goodbyes, their faces etched with a mixture of love, worry, and helplessness. They get to walk out the double doors back to their cars, their homes, their lives, and the patients are left behind. The click of that final lock echoes through the unit, a sound of absolute finality. You are sealed in for the night. The brief reminder of the normal world is gone, and the reality of your confinement crashes down all over again. The silence that follows the end of visiting hours is profound. It's a vacuum filled with the quiet hum of the lights and the loud roar of your own thoughts. The focus of the staff shifts. The evening is about containment and de-escalation. The goal is to get the unit settled and quiet for the night shift. Mental health techs will gently encourage patients out of the hallways and into the community room or their own rooms. They might put on a movie, something bland and inoffensive, that plays to a mostly vacant audience. Some patients will try to lose themselves in the flickering images on the screen. Others will pace, unable to burn off the anxious energy coiling in their stomachs. Some will sit and stare, their faces blank masks hiding internal storms. A few might play a listless game of cards, the slap of the cards on the table the only sound in a bubble of unspoken despair. Then comes the call for lights out. The overhead lights in the community room are switched off, leaving only the dim glow from the nursing station. You retreat to your room, which you likely share with a roommate who is a complete stranger, someone with their own struggles and their own nighttime rituals. There is no privacy. There is no real darkness. The lights in the hallway are never fully extinguished, and the small window in your door allows that sterile, observational light to spill into your room all night long. And this is when the true night begins. The external structure of the day is completely gone. There are no more groups to attend, no more meals to mark the time. There is only you, your thoughts, and the symphony of the psychiatric ward at night. You hear everything. The muffled sobs from the room next door. The sudden, enraged shout from down the hall. The rhythmic creak of the patient who paces the hallway for hours on end. And weaving through it all, the constant, unnerving jingle of the staff's keys. This is the sound of the 15-minute checks. Every 15 minutes, a face appears in the window of your door. A flashlight beam might cut through the dimness, sweeping over your body to confirm you are still there, still breathing. It is the ultimate paradox. A gesture meant to ensure your safety that feels like a profound violation of your privacy. You are being watched constantly. You learn to sleep through it, a shallow, restless sleep, always aware on some level that you are being observed. For those on a one-to-one, meaning they require constant observation due to being a high risk to themselves or others, a staff member sits in a chair in their doorway all night long, their presence a constant, silent weight. The night staff are a different breed. They are masters of quiet vigilance. The night nurse manages the entire unit, often with only 1 or 2 techs. They handle the late-night admissions that come from the emergency room. People in the throes of their worst moments, terrified, sometimes intoxicated, sometimes violent. The night staff have to assess them, medicate them, and settle them into a new and frightening environment, all while trying to maintain the delicate peace of the sleeping unit. They are the ones who sit with the patient who wakes up from a nightmare screaming. They are the ones who talk someone down from a panic attack at 3 in the morning, when the world feels like it's ending and dawn is a lifetime away. For a patient, the night is a lonely, terrifying frontier. It's when the depression feels heaviest, the anxiety is most suffocating, and the psychosis is most convincing. The distractions of the day are gone, and you are left alone in the echo chamber of your own mind. Sleep offers little escape, as it's often riddled with medication-induced nightmares or the kind of deep, tormenting dreams that only a mind in crisis can conjure. You lie there, staring at the acoustic tile ceiling, listening to the sounds of collective suffering around you, and you feel an isolation so profound it feels like it could swallow you whole. You pray for sleep, you pray for silence, but most of all you pray for the first faint hint of morning light, a sign that you have survived another night. The exhaustion is bone deep, a cumulative weight of sleeplessness, stress, and sorrow. And as the sky outside begins to slowly shift from black to a bruised, washed-out gray, a new kind of anxiety begins to build. The knowledge that in just a few short hours, the whole exhausting cycle is about to begin all over again. But that cycle, that relentless repetition, is also where the work is done. It's in the mundane that the monumental shifts can occur. The dawn doesn't just bring another day of the same. It brings another chance. Another opportunity for a medication to finally click into place, for a therapeutic breakthrough in a group session, for a moment of genuine connection with a peer who truly understands. The first sign of this change often comes around 9 a.m. After the morning medication pass and a breakfast that tastes like every other. The unit clerk will walk to the central whiteboard, erase a name from the community goals section, and write it under a new heading: discharge planning. A quiet ripple moves through the room. For the person whose name is now on that list, it's a jolt of lightning, a terrifying, exhilarating promise of freedom. For everyone else, it's a complex cocktail of emotions. A flicker of hope that they could be next, a pang of envy, and even a sliver of fear for the person leaving. Because everyone in this room knows that walking out those doors is not an end to the battle, but the beginning of a different, lonelier kind of war. The discharge process is a carefully orchestrated maneuver. It's a meeting with the full treatment team: the psychiatrist, the social worker, the therapist, and the patient. They sit in a small, sterile conference room, the same one used for admissions, bringing the journey full circle. They don't talk about a cure. They talk about a plan. A safety plan. Who do you call when the thoughts come back? What are your triggers? What are your coping mechanisms? They hand over prescriptions, a stack of papers with follow-up appointments, and numbers for support groups. It's a toolkit for survival. A fragile bridge being built back to a world that suddenly seems impossibly fast and loud. Then comes the final walk. Past the nurse's station, where staff members who have seen you at your absolute worst offer a quiet nod or a warm, "Take care of yourself." Past the day room, where the faces you've shared every meal and every group therapy session with watch you go. Goodbyes are often brief, awkward. There's an unspoken understanding that this place, for all its misery, has been a sanctuary. Leaving it feels like stepping off a cliff. You gather your belongings, the same clothes you came in with, now feeling like a costume from a different life. You walk to the heavy, steel-enforced doors. The tech uses a key. A loud mechanical clunk echoes in the hallway as the magnetic lock disengages. The door swings open, and for the first time in days or weeks or even months, you feel sunlight on your face that isn't filtered through reinforced glass. You take a breath of air that doesn't smell of antiseptic and reheated food. You are free, and you have never felt more vulnerable in your entire life. And as that person walks away, the staff turns back to the unit, back to the 20 or 30 other people who are still in the thick of their crisis. And this is where we have to ask the most important question: why? Why would anyone choose to work here? In a place of such concentrated pain, a place that is emotionally and sometimes physically draining? The answer is not in the paycheck. It's not in the prestige. The answer is found in the moments the outside world will never see. It's in the quiet victory of a patient with severe paranoia, who finally trusts a nurse enough to take their medication. It's in the faint smile of a deeply depressed individual who laughs at a joke for the first time in a month. It's the psychiatric technician who spends an hour patiently talking to someone in the grips of a terrifying hallucination, not to argue with the delusion, but to validate the fear and offer a calm, human anchor in a storm of psychosis. These professionals are masters of de-escalation. They are fluent in the language of nonverbal cues. They know that sometimes the most therapeutic thing you can do is not to talk, but to simply sit with someone in their silence, a quiet testament that they are not alone. They see not just the illness but the person trapped within it, the teacher, the parent, the veteran, the teenager. They fight, day in and day out, to help that person find their way back. They absorb the anger, the fear, and the sorrow of their patients, and they do it again the next day. It is a profound act of compassion, performed under fluorescent lights for an audience of one. But we cannot end this story here, with a simple portrait of dedicated staff and resilient patients. To do so would be to ignore the larger, uncomfortable truth. This ward and thousands like it across the country are not a solution to a mental health crisis. They are a symptom of it. They are an imperfect patch on a fractured, underfunded, and deeply stigmatized system of care. For many, the hospital becomes a revolving door. Patients are stabilized in a crisis, discharged with that fragile bridge of a safety plan, and sent back into a world with insufficient community support, long waits for therapists, and the crushing weight of stigma. They might lose their job, their relationships might be strained, and soon the crisis returns, and they find themselves right back where they started. The ward does its job, it saves a life in the immediate moment, but it cannot fix the societal problems that fuel the crisis. It's the emergency room, not the long-term care facility. It's the place you go when the house is on fire, but it can't rebuild the house for you. So what is the ultimate takeaway from a look inside these walls? It is that a psychiatric ward is not a place to be feared or judged. It is not a warehouse for the broken or a setting for a horror movie. It is a human place. It is a place of immense struggle, but also of incredible courage. The courage it takes to admit you need help. The courage it takes to face your deepest fears and traumas. The courage it takes to get out of bed in the morning when your own mind is telling you there's no point. The people inside these units are not other. They are us. They are a reflection of the fragility that exists in all of us. The line between sane and unwell is far thinner and more porous than we like to admit. What happens inside a psychiatric ward is simply a concentrated, amplified version of the human condition. The desperate search for connection, the fight for control in a chaotic world, and the universal need to feel safe and understood. The true purpose of a place like this is to hold a space for hope when a person cannot hold it for themselves. It is a temporary guardian of a future that the patient can't yet see. It is a testament to the idea that even in the darkest night of the soul, even when a mind is at war with itself, there is a fundamental, resilient, and unbreakable human spirit that is always worth fighting for. And the fight that happens inside those locked doors is one of the most profound and important battles being waged in our society today.